Welcome, welcome, welcome. Ravi has a POCUS case for us today and a POCUS VMR. Not claiming to be a POCUS expert, I'm just discussing the case. Ravi's going to interpret for us. Ravi is the expert POCUStician in the room. I just made that up. But hey, everybody, and welcome. Yasmin, do you want to say hey?
Hello, everyone. Of course, I am very happy and a little bit nervous because, as we mentioned, we are all learning POCUS today. And yeah, I'm very happy to see you all. And if you're watching us here right now or in YouTube, and you have a really nice case of POCUS, or even if it's bread and butter, and you want to present it, please reach out. We will be very happy to see everything with you. Again, thank you so much, Dr. Ravi.
Hello, everybody. Welcome to POCUS VMR. Hopefully we have some fun. And I'm bringing two cases for Andrew and Yasmin to sort of solve in real time the two cases you may see in the emergency room. And I just hope you have a lot of fun just trying to integrate this with POCUS and also the other components such as the history and physical and so on. So hopefully we'll keep it to 30 minutes for each case, and we'll start off with case one. All set? All right. So for the first case, you have a 29-year-old female who presented with severe radiating bilateral flank pain that's been lasting for about 1 week. The pain was constant. She described it as being pressure-like. She has a past medical history significant for constipation and also ovarian cyst. Associated with this, there was fever, there was vomiting, no vomiting of blood, no melena, no metachesia, and there was no dysuria, no frequency or hematuria that was mentioned. And I'll stop there for the initial discussion.
Yasmin, do you want to start us off?
Of course, just tackling the bilateral flank pain in a young patient, I will first of all think of renal causes, although nephrolititis tend to present unilaterally. In this case, a bilateral flank pain, I will think maybe something more, how to say, that can affect both kidneys, and also significant for constipation and ovarian cysts. This is my, and fever, I will think maybe this is a ascending UTI, pyelonephritis maybe, because if we have fever, we have radiating bilateral flank pain. My first thought would be, I would like to know what is going on with those kidneys. What would you do the first? What would you think, Dr. Andrew?
Yeah, my initial thoughts are it's kind of interesting. I feel like I never see bilateral flank pain. I don't think I've ever seen bilateral flank pain. So I'm kind of coming up with a new approach on the spot here, trying to kind of I'm basically in a type 1 thinking phase right now, just like what sticks out first. And I definitely did gravitate toward the renal system too. So I was thinking, well, what could cause bilateral kidney disease? It's much harder to do at the ureteral level because they're so like separated in space. So I'm wondering if maybe there's like a bladder obstruction or something like that with back pressure to both kidneys, something like that. The patient does have constipation. So if they have very severe constipation, that could potentially lead to urinary retention. But yeah, I'm definitely wondering if we're going to get a renal ultrasound from Ravi next. And questions I would ask are, has she been able to urinate at all? And does she have a history of stones as well, that we get some past medical history or two? And then just in terms of acute conditions that we don't want to miss, we're thinking of the back and kind of the renal system, but she is female. Should we like have a abdominal pain differential acute DDX as well? Perhaps we should talk about that too, but I'll just pass it off to Ravi and see what we get next.
All right, very good. So great questions that you have there and great thinking about this case. It's quite perplexing because it's something, I agree, yeah, definitely the flank pain brings up pyelonephritis high on my radar screen. But moving on to the exam, so the vital signs, she did have a fever, blood pressure was stable, 109/73, heart rate 101, respiratory rate 16, pulse ox was good, but just to cut to the chase, on physical exam, extreme tenderness on the left paraumbilical, left lower quadrant. There were no masses. The bowel sounds were sluggish. There was guarding, no rebound, no tenderness over the suprapubic region, and nothing on the extremities, nothing else that was remarkable. But just taking this exam into consideration, what are you thinking now?
The first thing I thought after, and I think the chat also like reading my mind, is I would like to know her gynecological history, because we also thought about flank pain in, we situate ourselves in the renal system. What about adnexal and uterine issues? Of course, it's a little bit more rare to find this kind of radiation, but she has a history of cysts. So I would definitely want to know if this person has been having like issues with her menstrual cycle, like dysmenorrhea, like, or maybe thinking about endometriosis, thinking about more cysts, or even having this, even if she doesn't have guarding, no rebound and only guarding, I would like to see if this could have, we could have the possibility of a ovarian torsion, although the presentation is much more intense. And of course, it's unilateral, because again, bilateral flank pain is putting me on, I'm thinking I'm hitting a knowledge gap here. What do you think, Dr. Andrew?
No, I definitely agree with you in the chat, thinking, like ectopic pregnancy for, emergent causes of abdominal pain in a female patient. But also just add torsion to that too. I wouldn't personally be putting the POCUS on for that. But yeah, I feel like we're probably going to get like a CT of the abdomen and then a POCUS of the abdomen and the pelvis next.
All right, very good. Yeah, definitely. While waiting for the CT, let's just kind of bring in the labs and see how this changes the landscape. So notable labs, white count was 15,000, hemoglobin 12, platelet 400, chemistry, sodium a little down, bicarb was up. She was also vomiting, and BU and creatinine 25 and 0.9, and the beta HCG was negative. And at this point, what would you guys think?
Not because I love ID and because I don't like anchoring, but with white blood cell, I'm thinking of urosepsis and thinking, well, pyelonephritis, and thinking, well, this might be an infectious process, or at least an inflammatory one, and definitely think she might have. Does she have any other like labs? This is like everything else, because I kind of see this as like normal.
Yeah, everything else was normal.
Okay.
The hepatobiliary, everything was negative.
Okay, and the UA?
UA was negative as well.
Oh, okay. So I'm thinking this could be an inflammatory process, infectious process, but having a UA negative, that is where I am wondering, like, if I would do a urine culture, sorry, but I don't know if that would be like a good next step. What do you think, Dr. Andrew?
Yeah, I think just rounding out like kind of an abdominal pain differential, because I know it's bilateral flank pain, but this is all kind of in the same area. I think I'm wanting like a CT scan with IV contrast, a lipase. I want to palpate the right upper quadrant and see if I get any pain in that area to localize. Feel the pelvis too. Although I guess we already did get the localization kind of to the pelvis. So really getting that ultrasound to rule out torsion or other adnexal pathology too is a good idea.
Yeah, I was just going to bring this in. It was interesting. She mentioned bilateral, but then the pain was left lower quadrant. Does that change your mind or bring up something?
I think that a migratory after being a general physician and listening to a migratory pain that goes to the left quadrant, I will think something more. And she has a constipation issues too. So I'm thinking, well, could she have like she's too young, but any issue with diverticulitis, any issue with like, or even colitis, like I'm thinking also, Abir made a very great point here. The chronic constipation may be explained by something like endometriosis. I really like that thought, thinking of what could be causing this left issue in a patient this young, 29-year-old, with history of constipation, with history of ovarian cysts. I'm thinking that could be one of the issues. Like I'm situating more into intestinal causes, and yeah, like that will be my train of thought after listening. This pain goes to the left quadrant.
I love all those thoughts, Yasmin. I'm excited for the next holocaust. I got nothing to add to that.
Absolutely. So we'll have the POCUS. I think Sanjay Patel is here, and his question was, is bowel obstruction on the table? That could be, but there was no distension. Bowel sounds were there. But we'll bring in some POCUS images. So putting the probe where the maximal tenderness first, usually it's what's helpful is asking the patient where the pain is, and then using I would use a curvilinear probe in the area of maximal tenderness and kind of compress in that area. You're seeing a transverse gut signature of the colon, and you're seeing this little outpouching. So transverse meaning you're seeing this sort of anechoic surrounding, which could be fluid. And there's usually like three to five structures that you could see. So you'll see the anechoic, which could be fluid. You'll see some fat stranding around here, hyperechoic inflammation. And then you'll see the muscularis layer, serosal layer, and the mucosa layer. So you see almost what you call something called a target sign. It looks like a target with a dot in the center, anechoic dot in the center. And this little outpouching here actually is, what do you think, Yasmin? Something you mentioned.
Honestly, I have seen like this kind of images like this. You see how we have like a little, this glass, like this little pouch. I'm thinking, could this be a diverticulitis? But there's another thing, like now that you mentioned target sign, could this be an obstruction or even an intussusception? Although what I'm thinking is that it, like in my conception of this, of the presentation of these kinds of pathologies, she doesn't show like so much like pain. She didn't mention any changes on how does it, like bowel movements, only that she has constipation, but she hadn't even mentioned that she had like this current jelly or any fecal issue, like fecal changes, right?
No. Just she has chronic constipation.
So yeah, like that little outpouching for me looks like a diverticulus, but then again, I am like trying to wonder if also this target signs could mean another, like an obstruction.
Yeah, in this case with the little outpouching there, it is indicative of a diverticula. And there are a couple of things when you have this much inflammation. It's kind of with this bowel being very full of debris and neutrophilic infiltration, so the white count was elevated, that it becomes rather stiff and non-compressible. So with trying to elicit compression, you don't get that move, the compression of the bowel. And then just to quantify the significant gut edema, again, you see all the layers here, and usually you look for increase in the size of the wall of the gut. And on the transverse layer, you see this gut signature is preserved. So, you know, this comes up if there's a perforation. These things can perforate. Sometimes you get an abscess and then it can perforate. So what happens is you lose gut architecture, or they call gut signature. So the different layers usually see this hyperechoic pericolonic wall, which is the outer serosal layer. Then you get this hypoechoic middle muscular layer, and then this echogenic interluminal layer, and that makes up the architecture of the gut. And you can see this is severely inflamed. So yes, this is a case of a patient with and especially a young patient. And we're seeing more and more patients with diverticulitis due to just poor bowel habits. Maybe there's some associated connective tissue disease as well. And just to also show a graphic of this target sign that I just showed to Yasmin. So again, you see this diverticulum or this dome sign and this massive amount of inflammation, hyperechoic fat stranding around this structure. So here, looking at normal, so I get a lot of questions sometimes when she's kind of showing this. Small bowel, you see the architecture with all the different plicae circularis. So you see the small intestinal loops of bowel here, and then you see the circular plica circularis that actually surrounds or continues throughout the whole circumference of the bowel here. And then you see the same thing here. You also see with small bowel, you see peristalsis. Remember the case 2 weeks ago, they mentioned also in the gut POCUS that there was also peristalsis that gives away that this is small bowel, which you don't see in large bowel. And then large bowel here, you'll see again, thicker wall, and you see the haustra, which you don't see. So this doesn't, you don't see the haustra run the whole circle or the whole breadth of the gut wall like the plicae circularis. So you can distinguish large colon from small bowel in that case. All right, so there are 3 POCUS indicators of acute diverticulitis. So thickened bowel wall greater than 5 millimeters, surrounding an adjacent diverticulum, enhancement of surrounding pericolonic fat, and sonographic tenderness to palpation. And again, the patient had this bilateral radiating pain, but when examined, the patient also pointed that the pain was maximum in that left lower quadrant. Any reflections on this?
Yeah, for sure. Yeah, I never see people put in probes on abdomens except to do paracentesis and like right upper quadrant. So this is really educational for me. I learned a lot about diverticular diagnosis with the POCUS. Now the bilateral flank pain, I think that goes to show you really don't want to anchor on kind of the location, because if you just do bilateral flank pain, I feel like, at least in my mind, that brought me pretty far from diverticulitis. I was thinking about that at all. So I think just keeping a broad differential for things around the abdomen, including like flank pain, is good. And then I did like the idea of intussusception that was brought to the chat. If you use that VPO mnemonic we have for kind of the emergent causes of abdominal pain, that'll add that one to the DDX, vascular causes, perforation, and obstruction. But yeah, what about you guys?
For me, I also got this knowledge gap of bilateral flank pain, that diverticulitis can also be in this. Think about it when you have a patient with chronic constipation. Also, in the chat, I learned that the lack of current through the stools doesn't necessarily mean that there's no intussusception. I thought it had always to be present. So thank you to Dr. Paul and to a beer that mentioned that on a women with endometritis, there can be obstruction due to this implantation of the endometrium and other areas. So those are like the pearls I'm taking to. And yeah, and that a diverticulus can look like a magnifying glass. Well, that's how I thought it looks like a magnifying glass, you know? So I really like this case. Thank you.
Yeah, absolutely wonderful. I think in the real world, yeah, when you're in the emergency room, you see somebody like this in real time, you're ordering the CT scan. And of course, that is the gold standard for this. But you can pretty much reach for a probe in any emergency room. And while you're waiting, just try and get an image and see what you can find. And there are a couple of great thoughts in the chat too. But I think Robbie mentioned this as well, I saw a case in the emergency room, and I think he tweeted about it as well. And sometimes patients tell you abnormal sort of like what you don't see in the textbooks in regards to pain. So I had a patient with chest pain, and it felt like a cardiac workup, somebody coming in with chest pain, angina, and only upon pushing on the abdomen, then the patient jumped up and said, the pain is really bad there. But then I asked, where's the pain? And it's making a circular movement across the chest, but the pain was really severe in the right upper quadrant. And the diagnosis immediately changed from cardiac-related chest pain to cholecystitis. So doing the labs, they were all abnormal. So always be curious when patient tells you where pain is, and also think outside the box, above and below the diaphragm. All right, on to the next case. So another case of abdominal pain to partner up with the initial one. So this is a patient, 23-year-old, coming into the emergency room, right-sided abdominal pain for 3 days. The pain's 5 out of 10 in intensity for about those 3 days, and described the pain as being colicky. There was no radiation. The pain was associated with nausea, but no vomiting. And he hasn't been able to eat because the pain has just been so tremendous. There were no bowel or urinary symptoms, no previous abdominal problems, no significant past medical history, family history, no alcohol use, no substance use, or anything else associated with this. So before we get to the exam, what's coming into your mind?
Well, now again, another young patient with no past medical history that has a mild intensity abdominal pain at 3 days in the right side. It situates me on like biliary, like gallbladder, anything like liver and appendicitis. Of course, it depends on where it goes, it radiates. But yes, I'm thinking so much about our friend Maddie's tutorial about like how the visceral peritoneum is first stretched, and that's what caused this like lack of localization until the peritoneum is stretched, and that's when we have like the patient can say, oh, it hurts here or there, like they can signal where the pain is. But if you're talking about right-sided pain, those are my first thoughts. And again, nausea, no vomiting, and loss of appetite, I'm thinking something more intestinal. But what do you think, Dr. Andrew?
Yeah, only addition, Yasmin, is just the acute emergent causes of abdominal pain in a male patient, just testicular torsion, kind of adding to pelvic etiologies. But no, that's a great initial DDX for this patient.
All right, continue on. Very good. Very great thoughts, guys. I think you're on the right track with this patient. So when you go to perform the physical exam, starting with the vitals, again, another patient with fever of 38.8, pulse rate 110, blood pressure 100/78, pulse ox 99%, room air. And the rest of the exam is normal, but I want to bring your attention to the abdominal exam. The abdomen is soft. There's significant tenderness and there's guarding when you press on the right iliac fossa. No rebound. And then some of these maneuvers that were mentioned in the chat for the first case, the Rothsing's, psoas, and obturator signs were not present. And how does this change your approach to this patient at this time?
Right now, I'm trying to think, like the first thing that came to my mind when reading guarding in the right iliac fossa was, of course, appendicitis. But right now, I'm trying to remember the Rothsing psoas and obturator signs pretest probability of like showing us if it's negative or like if having like how having a negative signs or a positive signs could change our DDX or our probability of having appendicitis, because this patient has only had 3 days and they have some fever, they have tachycardia. I will also like to see the CBC if he has leukocytosis, if they have anorexia. So of course I'm trying to fill up my Alvarado score. But then again, I don't know if this is like anchoring or if I should take into consideration other causes as well as like the ones that we already mentioned. Dr. Andrew, what do you think?
Oh, I still think all of that's on the table for sure, Yasmin. Only additions, the chat is on top of this. The right iliac fossa, That's also what I was thinking at first. Is this a hernia? Because there's direct hernias and there's indirect hernias. And I haven't done my general surgery shelf in a while. And I never see these hernias in young patients. So I have to try and recall which is which. But one of them goes directly through, I think, all of the layers of the fascia in the abdomen. And I want to say that's the one that's from kind of like chronic strain prior surgeries. And then I want to say the indirect, there's kind of like a pre-existing channel for bowel to slip through and kind of get caught. So if I got all of that straight, I think the latter may be at play because this patient is young and doesn't have like chronic abdominal wall defects. And then just testicular torsion too, because I think this pain is a little bit lower. So I guess we have the abdominal exam. We don't really see a hernia or there's no comments on it. So perhaps we are dealing with something in the testicle. I'm not too sure, but again, I think probably getting the CT, looking at the testicle as well, and then really feeling for a hernia would be helpful.
All right, very good. We'll move on to the labs, but yeah, the genitourinary exam was unremarkable, but great thought there, Andrew. Sometimes that can be skipped, and a process that could be present can be missed as well. And bringing in the laboratory exam, so there was a white count of 12.9, hemoglobin of 12, platelet count 350, neutrophil level was 74%, UA not really remarkable, and creatinine 1.2. But then just focusing on the white count and neutrophil level, what do you think?
I am anchoring on infection, right? An infectious process or an inflammatory process. And with the neutrophil level, I'm steering more towards an infection and thinking about, okay, could this be an infection? Where exactly? We have to determine the source. Like if this is coming from could this be an appendicitis? Could this be a renal issue? Could this also be any I don't think this is any other than those two. Those are the two main differential diagnoses. What do you think, Dr. Andrew? I think I'm anchoring too much on appendicitis, so I would really like to hear your thoughts.
Yeah, no, there's definitely inflammation going on. And then the only other thing I see are RBCs in the urine, which could be evidence that maybe there's kidney stone going on, whether that be concurrent, like incidental finding, or driving what's going on. I'm trying to think that the pain was like right-sided abdominal, colicky, constant, and then kind of like the right iliac fossa. So maybe that would be like a stone lodged in like kind of the distal part of the right ureter or something like that. But that's really all this adds for me. I think there's just this just confirms our signal for inflammation and then adds the possibility of kidney stone, just a possibility.
All right, wonderful discussion there. I just kind of was interested. I didn't look up the sensitivity specificity of the Rolfs-Singh's obturator sign, psoas sign, but I just did a quick search. And Rolfs-Singh's has a sensitivity 7 to 68%, specificity 58 to 96, psoas 13 to 42, sensitivity 79 to 97, specificity obturator 8 and 94. And then if you look at the likelihood ratio, obturator is non-specific, and very low likelihood ratios for both. Rolfs-Singh is about 2.3, so it's 2.0. So not great. And they were negative in this patient. But so your next step is putting a POCUS onto, again, asking the patient, where is this pain the worst? And the patient's like mentioning or pointing to the right lower quadrant. So taking your curvilinear probe and putting it onto that area, then you follow the ascending colon, which would be here. So the ascending colon would then merge into the cecum. And then from the cecum, you have the psoas muscle here, this superficial skin, subcu tissue, and then you would have this sort of transverse structure here. Again, it kind of looks like the target sign, but this is the appendix, which is remarkably inflamed. And again, you see this hyperechoic surrounding tissue, which is echogenic. So there's frat stranding. when you try and move the probe into a transverse, into longitudinal configuration, you see the appendix is again surrounded by anechoic signoso periappendiceal fluid, and then inflammation, and then you also see then the hyperechoic inflamed wall. So the wall would have to be thick, around, I think a normal appendix is less than 6 millimeters, and this would be greater than 6 millimeters in that case. And again, applying the rule that we had in the first picture with diverticulitis, it would be non-compressible again, because there's so much inflammation and cellular infiltration into the surrounding areas. So this, in this case, you'd see an inflamed appendix. And one way of it can be very difficult. Sometimes I have difficulty trying to find it in a normal patient. You may not see the appendix, but you follow the probe down the ascending colon, and then you come to the cecum. And the cecum has this really nice kind of floral appearance because of the rugae. And then, lateral to that would be the appendix, and lateral to that might be the iliac vein. And below that, you may have the aorta come in and out. You may have the psoas musculature. And this kind of also helps you to orient yourself where to look for the appendix. So usually this appendix will be this serpiginous kind of configuration, but when you have that much inflammation into that area, it becomes quite straight and distended, and you can see it. And usually we'll cross the iliac artery and then the psoas muscle. And when you have appendicitis in a transverse configuration, it could be in one of these sort of it could appear in sort of more a flattened, more swollen, or you see a more exaggerated lumen. And then here you see the iliac artery and see the psoas muscle here. So cecum is here, again, that floral appearance in a transverse configuration of the iliac artery. And if you sweep distally, it should then show the appendix in that case. And if you look again at the walls, that gut signature is important. So again, I kind of want to emphasize gut signature. When you have loss of that gut signature, which is seeing integrity of all the different walls, so the serosa would be echogenic, so that would be the top part there. Muscularis would be hypoechoic, or a slightly lighter gray than surrounding areas. Submucosa would be echogenic, and the muscularis mucosa again would be hypoechoic, and the mucosa would be echogenic in the middle there. And you see again this sort of a target appearance. When you have loss of that gut signature or all these layers, then you could have a perforated appendix in that case. And that would be a patient that would present in a much more toxic manner. And mimics you have to be careful about, definitely inflammation from disease states, gas-filled appendix, mucocele of appendix, or lymphoid hyperplasia. So that pretty much is the second case. Any reflections, Andrew, Yasmin?
Honestly, same as the first. Radiology is so helpful. I have a hard time putting a lot of stock in abdominal pain localization. It's incredible you can get an answer this quick with the probe. Also, awesome images, Ravi. Those are great.
Yeah, that's what I was gonna say. Like, I think that the most difficult task in POCUS is getting the probe correctly and knowing where to situate yourself to get the whole image complete. And yeah, for this one, I think that being able to measure the outer wall to the inner wall of the appendix to see if it's more than 6 millimeters, and also the gut enhancement. I think the gut signature could help us determine if in this case would be perforate or not. Those are the two main pearls I'm taking from the case. And yeah, thank you so much for this very interesting, we're now looking at the gut in POCUS.
Oh, absolutely. It was fun. I think we've done through over probably about a year and a half of POCUS VMR. We've done a lot of cardiac, we've done a lot of lung, abdomen less, and I think it's difficult. Even I have difficulty. I'm not too experienced in it, but you keep trying, and like I mentioned, in any institution, you're able to find a point-of-care ultrasound device in any emergency room, and you should be able to at least utilize it and learn while you're waiting for the CT scan. Of course, we're going to have to confirm this with the CT scan, but it does help. Say you're somewhere, maybe doing service in a foreign land, and you have a butterfly on you, and we're doing quite a bit of that, where we're purchasing devices for people that are abroad, in underserved areas. There was recently a trip to Haiti, and we were able to send some butterflies there for the practitioners and even help them learn point-of-care ultrasound. So it can be very useful in the field, or even in a clinic if you see a patient where you don't have a CT scan available. But great job, at least going through the steps and the reasoning steps for these cases. I think that the cases that you will see in the emergency room, and you have to have a high suspicion for these dangerous conditions where patients can get very, very sick very, very quickly. I think Sanjay Patel's here, who is a great teacher of point-of-care ultrasound. Are you able to unmute and maybe share some pearls of wisdom with us? I'm not sure if he's still here, but if not, that's okay. All right, yeah, I don't see him here, but I think he was here for a little bit. But should we go to teaching points?
Of course, I'm not sure like if Mariana or Gia. I think Gia was describing and Mariana was in teaching points.
Yes, sure, I'm ready. So for the case one, we started with bilateral flank pain that after physical exam pointed to left lower quadrant pain, and we discussed like common causes of abdominal pain. We also discussed constipation causing bladder obstruction, and also gynecological causes such as ovarian torsion, ectopic pregnancy, endometriosis, and also intestinal causes such as diverticulitis and bowel obstruction. And we had a white blood count of 15, other labs within normal limit, and UA negative. With this scenario, we needed more exams, and Dr. Rabi performed an ultrasound in the abdomen, and it's really interesting because we can use the ultrasound in the abdomen for other things aside paracentesis. So with the ultrasound, we could diagnose the diverticulosis, and this is really also really interesting here because we had diverticulitis in a patient, like in a young patient, that is a sign of bad eating habits. And of course, the gold standard exam for abdominal pain is a CT, but a POCUS can be faster and can reveal diagnosis in some case. So if you have it and if you know how to use it, you can help your patient like in a faster way. And in the second case, we had abdominal pain for 3 days. We discussed appendicitis, hernia, diverticulitis, kidney stone. And in a male patient, it's also important to consider testicular torsion. In this case, we had a patient with a negative Rovsing sign. But we also discussed that it is really interesting that you cannot rule out appendicitis because a negative Rovsing sign. And POCUS hint in this case was put the probe where the patient says the pain is worse, and you probably find something in that area. And in this case, we had the image finding of periappendiceal fluid and inflammation, and the appendicitis was diagnosed. Thank you so much for this amazing case, Dr. Ravi. Thank you, Yasmin and Dr. Andrew, for the discussion.
Wow, incredible. I looked at that whiteboard. You just filled it up with everything. That's amazing. So thanks for putting it together. Great job. Great teaching points, Mariana. All right. Thank you, Yasmin. Thank you, Andrew, for discussing. I just wanted to bring some straightforward cases that you may see in the emergency room when seeing patients, and absolutely fabulous job discussing these cases. I guess, Andrew, you want to take us out?
Am I supposed to make that noise that Robbie makes, the doot to do?
All right.
That's all I
Bye.
get.
Take care, man.
Bye, Robbie. See you.